Hey guys, my name is Megan Cochran, and I am a fourth-year med student here at UCSD. The CRE, or Clinical Reasoning Exercise, is an educational tool designed for you guys, third-year med students. It is my hope that this exercise will be helpful when you are approaching your patient's clinical problems during the Medicine 401 clerkship. The outline of this presentation will be as follows. First, we'll go over the background of the CRE, which includes logistics and grading. We'll conclude by going over an example CRE. Please refer to the other YouTube video or PowerPoint titled A Review of Clinical Reasoning to learn more about the concepts of clinical reasoning, as this tutorial will only be addressing the exercise itself. First and foremost, thanks for being a part of this activity, and welcome to the CRE. During your internal medicine clerkship, you'll see a large variety of different clinical problems in pathology. As you spend time on the hospitalist service, you'll start to see that you and the team are the patient's first-line defense to any medical problem that they may have. Initially, this may be a little overwhelming, but keep in mind that no one expects you to already know all the answers. So from the med student perspective, things like getting a good history and exam, conducting oral presentations during rounds, and writing patient notes are going to be key components to this rotation. However, it's important to realize that underlying all of these activities is the complex process of clinical reasoning. As MS3s, you guys are making the big transition from a predominantly didactic environment to that of a clinical one. With that being said, the CRE was created as a tool that would help you guys in developing a systematic method for approaching various clinical problems. So what is the CRE? The CRE is a self-directed educational exercise that provides step-by-step guidance through the clinical reasoning process. And the goals are as follows. Number 1, to enhance student clinical reasoning abilities and skills. Number 2, promote formation and storage of knowledge in a clinically relevant manner. Number 3, to facilitate conversation between faculty and students on clinical reasoning. And 4, reveal and address any potential errors in student clinical reasoning. A few comments on logistics and assessment. So each student will complete 2 CREs during the 4-week inpatient rotation at the VA. So each CRE that you complete will be in conjunction with 2 of the 4 graded H&Ps. In other words, the CRE and H&P should be turned in simultaneously, either via email or printing them out and turning them in by hand to your attending. With regards to assessment, you will not receive a grade for the CRE. Let me repeat, you will not receive a grade for the CRE. This is because this is still being trialed into the curriculum and is only located at the VA inpatient site. So this is a summary of what I said on the previous slide, and if you're a visual learner like me, this will make a little bit more sense. So you'll notice again, there are a total of 10 H&Ps that are due over the course of 4 weeks. Now, 4 of these 10 must be graded by an attending, so those are denoted in the red font. With regards to the CRE, in this hypothetical example, the student chose to complete them during weeks 2 and 4. Alternatively, they could have chosen another 2 weeks, say like weeks 1 and 3. The important thing to realize is that the student completed the CRE with the H&P and turned it into the attending at the same time. A final comment that I would like to make on this slide is that this does not include every requirement for the clerkship, so please refer to your syllabus for other required activities and specific deadlines. So before we go over an example CRE, let's briefly review the key components of clinical reasoning. So the first component, problem representation, is the 1 to 2 sentence summary that highlights the key features of a patient's case. It's often referred to as the identification or ID statement, and it's really important in facilitating problem solving and communicating with other physicians, not to mention your oral patient presentations. Recall that problem representation utilizes semantic qualifiers, which are paired opposing descriptors, such as bilateral versus unilateral or acute versus chronic, and includes the who, when, and what of a patient's case. The second component is diagnostic schema. Schema are cognitive tools that enable a systematic approach to a given clinical problem. I personally like to think of them as different frameworks. Some examples that we discussed previously included the organ system approach, vitamin deck, and anatomical or physiological constructs, although there are many other different kinds of schema. The third concept is illness scripts, which are organized mental summaries of disease knowledge. I like to think of illness scripts as a typical patient presentation or story. Usually, we access and store illness scripts mentally in a compare and contrast format, with the key point being that there are certain features of diseases that define that disease. Now that we revisited the key components of clinical reasoning, let's go over an example CRE. So the next couple of slides are a series of screenshots taken from a Word document that has a completed exercise, and this slide shows the first two steps. Step 1 consists of some identifying information. Step 2 entails identifying a clinical problem and then a goal with regards to that clinical problem. Please recall that a clinical problem can range from anything like a symptom, such as dyspnea on exertion, to an exam finding, like ascites, to abnormal lab values, like normocytic anemia, or imaging findings, such as a solitary pulmonary nodule. In this particular example, the clinical problem that I have chosen is a symptom, specifically sudden onset of right knee pain. My goal for that stated clinical problem is to develop a differential diagnosis for acute onset of monoarticular arthritis in adults. Next, let's review some tips for success. So first and foremost, the clinical problem would ideally be the chief complaint or the reason for admission. If this is not the case, it's okay, and we'll review an example of this later. Second, try to pick a clinical problem that isn't too broad. For example, doing a lookup on chest pain in adults would likely be really challenging. Going to the other end of the spectrum, try to avoid problems that are too specific and give a slam dunk diagnosis. Step 3 consists of applying the clinical reasoning concepts. Let's go over Part A, Problem Representation, which again is the 1 to 2 sentence summary that highlights the key features of a patient's case. Here you can read the difference between a novice and an expert. While both utilize the general framework as outlined below, you'll notice that the expert uses much more semantic qualifiers, which allows for a more succinct summary using appropriate medical terminology. So some tips for the ID statement are as follows. First, stick to the general format, include the who, when, and what. You'll notice that during both oral presentations and note writing, most physicians adhere to this series of information. Other tips include using semantic qualifiers and avoiding fluffy language and distracting information. Finally, keep in mind that it's okay if your chosen problem isn't even mentioned in the ID statement. For example, if you have a patient that is admitted for sepsis due to pneumonia and your chosen problem was an AKI, you may not even need to mention this in the identification statement. Part 3B consists of picking a diagnostic schema to address the stated goal and clinical problem. In this particular example, I chose a vitamin deck approach to generate a differential diagnosis for acute monoarticular arthritis. So there are several things to note on this slide. First, not every category has a diagnosis, and this is okay. Do your best to list relevant diagnoses, and don't try too hard to list something in every category just for the sake of listing something. Also, please keep in mind that there are many other schema to choose from, so don't stress if you feel like you picked the wrong schema. Remember that this is a learning exercise and you will not receive a formal grade. Another tip is to pick your resources wisely. While UpToDate is a great tool, I personally find it higher yield to first reference something like Pocket Medicine or Step Up to Medicine first. The reason being I like to get a big picture of the clinical problem and then read about the details on UpToDate after. As a side note, for those of you who don't know what Step Up to Medicine is, it's a textbook commonly used by third-year med students. I have posted a link in the comments section, which is part of the MS3 Clerkship online resource. You should definitely check it out. Now we see the third component of clinical reasoning in Part C, which is an illness script comparison. Here, you should pick the top 3 diagnoses that are most likely for your patient. In this example, I picked gout, pseudogout, and septic arthritis, and subsequently compared these diagnoses to one another. Please recall that the purpose of illness scripts is not to list every single little fact about a disease. More importantly, illness scripts should really highlight the salient features of a disease and compare that to salient features of other diseases. By the end of this exercise, you should start to develop a typical patient story for each of the diagnoses in the form of an illness script. This slide shows step 4, which is the assessment of the clinical problem. In order to best demonstrate your diagnostic reasoning, you should first comment on what you think is the likely diagnosis and why. Your supporting data will likely be a combination between the presentation, exam, and diagnostic workup. You should then go on to discuss other diagnoses that are still possible but less likely. Finally, you might want to include any can't-miss diagnoses. If we compare the novice and the expert, you'll see that the novice presents an unorganized conglomeration of random facts, whereas in the expert, we see a logical progression that uses supporting and refuting evidence. The expert first lists their leading diagnosis of gout, and then provides support for this claim, most notably the past medical history and joint aspiration findings. He or she then discusses the can't-miss diagnosis of septic arthritis and provides evidence that refutes this diagnosis and excludes the need for antibiotics. He or she then concludes by excluding other causes, such as rheumatoid arthritis and osteoarthritis. Step 5 is a reflection process and consists of the 4 questions noted below. Question 1 asks you to summarize key learning points that you will take away from this exercise. Hopefully, the CRE helped you store information in a clinically relevant manner. Question 2 asks you to list where you obtained your information. Please make sure that you are using reliable resources. Question 3 asks if you believe this will be a useful framework when seeing patients in the future. Ideally, the answer is yes. If not, reflect on why this approach was not particularly useful. This may also be something that you can discuss with your attending. Finally, question 4 asks you to list any challenges that you faced in the clinical reasoning exercise. For me personally, I found that there was some variation with regards to defining septic arthritis with joint aspiration findings. This is something that I can ask my attending about, and hopefully they can help clarify. The 6th and final step consists of attending feedback. Again, please remember to turn in the completed CRE with your completed H&P, so your attending can review them together and provide feedback for both. This concludes the end of the presentation. Thank you so much for your time and attention. Please feel free to email me at mkcochran@ucsd.edu for any questions, comments, or concerns. You may also contact my ISP committee, Drs. Goldberg, Kwan, and Furkandapour, whose emails are listed below. Finally, there will be a brief summary at the end of the rotation where you can comment on your experience and provide feedback anonymously. Thank you again. I hope you have a great time on your Medicine 401 clerkship. This concludes the end of the presentation. Thank you so much for your time and attention. Please feel free to email me at mkcochran@ucsd.edu for any questions, comments, or concerns. You may also contact my ISP committee, Drs. Goldberg, Kwan, and Furkandapour, whose emails are listed below. Finally, there will be a brief summary at the end of the rotation where you can comment on your experience and provide feedback anonymously. Thank you again. I hope you have a great time on your Medicine 401 clerkship.